Hello everybody, welcome to RAAONLINE. I'm Dr. Abinaya. I'm a consultant pediatrician and your pediatric teaching faculty at RAAONLINE. So this presentation is an approach to inborn error of metabolism, and I have included this in the neonatology chapter. And you'll be having few more presentations about the individual metabolic disorders in the another chapter discussion, which will be genetics and metabolism. So this is just for you to get an overview only. And I have seen in the previous year question papers, you are all given some case scenarios especially, and it is quite simple. So what one needs to understand, an exam going student needs to understand is, you will be provided with case scenarios and you will have important clues over there and how to proceed further, right? And this is predominantly based on two guidelines, and I think this is quite simple, so we will get started. And any other metabolic disorder that you would like to for me to address separately, you can write to us also. Okay. So what is an inborn error of metabolism? So there are many metabolic pathways. A defect in any of these metabolic pathways, if there is a block, it results in these IEMs. And what happens when there is a block is, once there is a block, the substrate gets accumulated. All the metabolites prior to the block will get accumulated and you will not receive the end product. So the end product could be a functional protein. It will not be available. So toxins get accumulated and there is an absence of functional protein. So there are varied case presentations, and more than 1000 IEMs are present up to date, and we have selectively access to investigation to few of the inborn errors of metabolism. But the cornerstone for diagnosis is, of course, when you suspect. So suspicion is the key to diagnosis. So I'll tell you when to suspect an inborn error of metabolism. Say in a neonate and infant, you have around 10 points I have given here, and it differs from an older child. For an infant or neonate, you just in NICUs and in nurseries, you would have seen a lot. So a baby who has most of the times we do get babies like you discharge the baby on day 2, day 3, they come back day 4, day 5, severe dehydration, severe vomiting. So the baby was apparently normal for probably a period of 48 to 72 hours, and then they return in a crisis. So this is one of the most common presenting history. So deterioration after a period of apparent normalcy. And always ask during our case history taking, always ask for a parental consanguinity. And when you take a family history, ask for any previous history of miscarriages, any IUDs, any history of high drops previous, and family history of neonatal deaths. So not just this, when you do the three generation pedigree drawing, always ask for neonatal deaths. Most of the times the family members will not be aware, even that particular couple, they will not be aware of other neonatal deaths. But once you probe them, so you have to ask like if there was any babies who were born at a very young age and they have passed away. So if any details are present, it is going to be very, very crucial, right? And the history in the mother. So if the mother had history of HELP syndrome, that is hemolysis, elevated liver enzymes and low platelets. So this is a very vital history. If this was present or a fatty liver was present, fetus with long chain acyl-CoA dehydrogenase deficiency. So this particular metabolic disorder, so presence in utero with the mother giving out symptoms, like so the mother experiencing this HELP or an acute fatty liver, and a neonate who has seizures and encephalopathy. So these seizures are very severe, intractable NKH, biotinidase deficiency, pyridoxine dependent seizure, folinic acid responsive seizure, or some of the metabolic disorders which present directly with intractable seizures. So only when you provide the cofactor, only when you provide the substrate, or the seizures can be aborted. And recurrent encephalopathy or a rapid encephalopathy, so urea cycle disorders, so rapidly progressive encephalopathy will be present. And metabolic acidosis, which is very, very severe. So maybe a birth asphyxia was present, but it is not corroborating with the severity of birth asphyxia. So that should raise a suspicion. Probably, maybe birth asphyxia. Along with that, what if the baby has an inborn error of metabolism? A jaundice, a severe jaundice and a severe liver cell failure in the first few days after birth. And persistent vomiting, I told you once, like galactosemia, the baby is well on day 1, you discharge on day 2. Once the feeding, the baby goes in full feed, the baby comes back to you with severe feeding, severe vomiting, dehydration, jaundice, liver dysfunction, persistent vomiting. In some instances, very peculiar odor that the family members usually tell. Whenever we change the diaper, we get a very, very peculiar odor, musty odor, a sweet odor like a maple syrup. So all these should definitely suspect. And a sick child, you have ruled out a very sick child, you are treating for sepsis, but the baby is not responding to the routine treatment. Definitely suspect. Okay. So why all these are important is because these metabolic disorders are very high, like we don't realize. So there is an ICMR article which I have put it up in one of my video lectures. So there the incidence is as high as 1 in 800. And most of these, like the admissions, they get admitted in the NICUs or in the PICUs, and they have around 30-35% mortality, so which is quite high, because frequently they present with life-threatening crisis. So identification is very, very important. Only then you can start early treatment. Then importantly, for prognostication of this particular index child, and to prevent the other neurological damage, and more so ever, if you identify this, most of them are single gene disorders, autosomal recessive inherited disorders. So counseling of the families in case they are planning for the next child, antenatal diagnosis, all these are very, very important. And if you, in case we miss to pick up a diagnosis in that particular child and the child or the baby has lost his life, so we need to take adequate postmortem or autopsy specimens with the permission of the family, and then preserve it or do a metabolic screen in that particular index case. And so these are the pointers where you would suspect IEM in a neonate or infant. There are certain points where you would suspect IEM in an older child also. So when you have a child with dysmorphic features, you find, there are many syndromes with dysmorphic features. I have shared a few images over here. So when you have a dysmorphic feature, a baby with, so you can start from top, like from the head to toe. So recurrent encephalopathy, okay, seizures, mental retardation, developmental delay. Coming to the eye examination, so eye will have many features which are typical, like a cherry red spot in Tay-Sachs, Niemann-Pick's, retinitis pigmentosa in mitochondrial disorders, cataract in galactosemia. So any atypical findings on ophthalmic examination. Then coming to heart, cardiomyopathy and muscular myopathies, liver failures, hepatosplenomegaly, storage syndromes. So all these will should raise doubt in your mind. So what if this could be an IEM? And then start your evaluation. So this again is this is some of the images I am just sharing it with you. So this is an oil droplet cataract which is seen in galactosemia. So typical appearance of oil droplet cataract, but it is not seen in the newborn stage. So this is something that we see at a later childhood age. And these are all syndromic babies. So as you can see here, yes, mucopolysaccharidosis. So they can present with coarse facies, cataract. So definitely raise a suspicion. And this is retinitis pigmentosa seen in many mitochondrial disorders. This is cherry red spot seen in many storage disorders. And these are some of the syndromic babies. So it's a Zellweger syndrome baby with hypotonia, upward slanting of the eyes, and hepatosplenomegaly, eye involvement with sulcation defects on MRI. So this is Zellweger. This is a baby with a biotinidase deficiency. So very clearly you can see the seborrheic dermatitis and then rash in the perianal region. Extensive rash will be there. The baby can have rash, sparse hair, and eye involvement, conjunctivitis. So all these are features of biotinidase deficiency, typically presenting with seizures resistant to treatment. So this is Menkes kinky hair syndrome. So typical hair appearance. And this is phenylketonuria. These two babies are phenylketonuria babies. So look at the skin tone. So very, very light skin toned, blonde hair, typical blue eyes. Some eczema is present in the perioral area. So these are all some of the images that I have shared. So all the, any dysmorphic features, any abnormal findings on physical examination should definitely raise a suspicion for inborn error of metabolism. So we can classify IEMs as 5 broad groups. So one is the intoxication group. For example, the urea cycle defect. So what happens? The toxic metabolites will get accumulated and then that can cause issues. Energy failure group. Example, mitochondrial disorders. Storage disorders, we know mucopolysaccharidosis, lysosomal storage disorders, etc. Seizures. So I told you many seizure disorders, NKH, biotinidase deficiency, all is folinic acid responsive seizures, pyridoxine dependent, etc. Liver cell failure. Liver cell failure can be liver cell failure without cholestasis is also possible, with cholestasis is also possible. So broadly, we can have this classification of inborn errors of metabolism. So now we will move on to the acute presentation of inborn errors of metabolism. So this intoxication group and the energy failure group are the two groups which usually present acutely, right? So I just told you those presentation with severe dehydration, with severe metabolic acidosis and ketosis. So these are the predominantly two groups. So intoxication groups are example urea cycle defects first, then organic acidemias and some aminoacidopathies. Energy failure groups are mitochondrial disorders and fatty acid oxidation defects are the energy failure groups. And so this is again a pattern of presentation, because so we will when we approach a case, it is difficult for us to identify that particular metabolic disorder just by the clinical examination. But when you have such babies, what is the predominant mode of clinical presentation? So at the end of your clinical examination and with the supportive investigations, that is the basic preliminary investigation, you should have some 3-4 differentials in your mind. Okay, so that is why I have put this here. Say a baby has presented to you with encephalopathy, there are seizures, some tone abnormalities is present. Whenever there is encephalopathy, always think of that acute presentation. I told you, that those two, the ones which present as intoxication group and the energy failure group. So these two are the ones which usually present with encephalopathy. So intoxication group like urea cycle defects, there's aminoacidopathies, few aminoacidopathies, organic acidemias, even mitochondrial disorders can present with encephalopathies, which present with intractable seizures. You have treated, you have given phenobarbital, you have given Levipil, you have put down midazolam coma, still the baby is throwing seizures, intractable seizures. You will have only 3 to 4 in your mind, right? One is NKH, second is pyridoxine deficiency, third is folinic acid, fourth is GLUT1, fifth is molybdenum cofactor defect. How many? So just remember these 5. Whenever there is intractable seizures, remember these 5, okay? NKH, pyridoxine dependent seizures, folinic acid responsive seizures, GLUT1 transporter defect and molybdenum cofactor defects. So when you have certain presentations, you have these differentials with you, right? And when there is jaundice, say unconjugated jaundice, very high levels, 24, 30, you will have Crigler-Najjar syndrome. Gilbert will not have very high values, but still an unconjugated jaundice, you have these two. Very, very early onset of hepatomegaly, you have to keep tyrosinemia, you have to keep galactosemia, neonatal hemochromatosis, all these as your differentials. When there is cholestasis, think of alpha-1 antitrypsin and Niemann-Pick type C, okay? So when there is unconjugated jaundice, think of Crigler-Najjar. When there is cholestatic, you think of alpha-1 antitrypsin and NP type C. Severe refractory hypoglycemia. We had one video lecture on hypoglycemia and infant of diabetic mother. So hypoglycemia, I have given you. Towards the end, I have divided hypoglycemia as recurrent and refractory hypoglycemia into 2. One is conditions with the hyperinsulinemia and conditions without hyperinsulinemia. So in that, if you see normal insulin but recurrent or refractory hypoglycemia, you will have certain disorders. So some endocrine disorders I have mentioned, some metabolic disorders. In that you can find these. So the gluconeogenesis disorder, some GSDs, galactosemia, fatty acid oxidation defects, all these can present with hypoglycemia. So based on the clinical presentation, you can write your differentials accordingly. And once you get the reports, it is easy for you to correlate. Always look for the dysmorphic features and the cardiac diseases. Some diseases like, for example, POMPs, which is glycogen storage disorder type 2. They present with hypertrophic cardiomyopathy. Fatty acid oxidation defects can also present with cardiomyopathies. Mitochondrial electron transport chains can have cardiac failures. So some cardiac presentations are also possible. So now that you have a baby with you and there is a sudden deterioration and you think that, okay, I have ruled out sepsis, and there is no birth asphyxia, nothing, but the baby has severe metabolic acidosis. Now I have decided to do a metabolic workup. So what all you will do? Okay, straight away don't go to TMS, GCMS. Wait, our basic blood investigations will give a lot of clues. Okay, so start with your complete blood count. So start with your complete blood count. So complete blood count, look at the hemoglobin, look at the WBC, and look at the platelet levels. Certain organic acidemias can have neutropenia and thrombocytopenias also. So propionic acidemia, methylmalonic acidemias can have neutropenia and thrombocytopenia, right? Okay. So next is do check for acidosis or not. So you do an arterial blood gas, do a RFT and electrolytes. Arterial blood gas will tell you if the pH is normal or if the pH is low and what kind of acidosis it is present. Next, look for blood glucose, hypoglycemia or normoglycemia or hyperglycemia. If there is hypoglycemia, always do urine ketones and plasma ketones along with that, because based on the presence of ketones, you can narrow down the differentials very well, right? Next, you do an ammonia and lactate. Plasma ammonia levels up to 90 to 150 is normal, which is microgram per deciliter, but beyond, sometimes even beyond 150, 200, urea cycle defects will have some very high plasma ammonia levels. Do on blood lactate, which is arterial blood lactate level should be done, and up to 1.5, 1.6 it is normal. Do a liver function test, renal function test, urine ketones, serum ketones, urine reducing substances, especially for conditions like galactosemia, and serum uric acid. Serum uric acid is for this condition only, molybdenum cofactor deficiency, because it doesn't have much of other lab investigations which are favorable. So serum uric acid will be low in molybdenum cofactor deficiencies. So this is your preliminary investigation. Okay, please take a note and keep it with you. So it is always your preliminary investigation, which you can do it in your own facility. Of course, TMS and urine GCMS, we are going to outsource this if we don't have the facility. But these investigations, it is present in most of the hospitals. 99% of the hospitals it will be present, and it is immediately available also. You can get the reports in 1 or 2 hours, and with those reports, you can then work out, okay, what kind of IEM it could be, right? So once this is available, then you proceed to the second line investigations, which is TMS. In TMS, you will have the amino acid profile, acyl carnitine profile, it will be present, and then you send urine for organic acids, that is urine for gas chromatography and mass spectrometry. And some other second line investigations are, once you have this lactate levels, you can also take the pyruvate levels. So lactate pyruvate ratio we have to see. Urinary orotic acid, especially in urea cycle defects, for identifying exactly what urea cycle defect it is. And specific enzyme assay. So in case you have a strong suspicion that it could be like lysosomal storage disorders like MPS, or you have strong suspicion that is galactosemia, you do available the enzyme assays, even biotinidase also. And so enzyme assays are not available for all IEMs. For few IEMs it is available, especially biotinidase you can do in the newborn screening only. So the 6-7 package only biotinidase is checked. So enzyme assays are all coming under second line investigations. Okay, so you have the first line investigation with you. Now we will see approximately how you can narrow down which IEM it could be. So first is look at the plasma ammonia. Ammonia is normal or it is high. So if it is normal, so this we will look at this arm first. So plasma ammonia is normal. Then look at the blood pH and carbon dioxide. Here if there is no acidosis, okay, ammonia is normal, blood pH is normal, then you have to have certain all these disorders. So these are all some common disorders I have written. Okay, there are so many IEMs, but what we generally see, and I would like to like you all to go through that ICMR paper on genetic disorders in India. If you want, I will share it also. And so they have given the common disorders in India. So common organic acidemias and common aminoacidopathies with percentages. So we have to keep those common disorders first whenever we come across IEMs. So normal ammonia, no acidosis, then think of certain amino acid disorders, galactosemias, peroxisomal disorders. The peroxisomal disorder will have some dysmorphic features, you will get some ideas. Sulfate oxidase deficiency also will have certain dysmorphic features. So this is one arm. Say you have plasma ammonia which is high. and you look at the blood pH and carbon dioxide, you have acidosis. Once you get acidosis, look for the presence of ketosis or not. Acidosis is present but no ketosis. We have arrived at the diagnosis of fatty acid oxidation defect. So further we can get further information about what fatty acid oxidation defect we will have from our TMS reports. Okay. So acidosis, no ketosis, high ammonia levels, always think of this. Sometimes fatty acid oxidation defect can have a normal ammonia also. One more clinching feature here is presence of hypoglycemia. And so plasma ammonia is high, blood pH is normal, no ketosis. Think of urea cycle defects. So urea cycle defects will have high ammonia levels, but pH is normal. Okay, and based upon the level of plasma citrulline, we can narrow down which part of the urea cycle defect is in problem. So I will discuss on urea cycle defect in the genetic chapter. Okay, so I am stopping right here. And one more is we have looked at serum lactate levels also. So lactate levels is usually positive in mitochondrial disorders and certain organic acidemias. Okay, so lactates are very, very high in mitochondrial diseases, and some organic acidemias it can be high or normal. So with this in mind, what you can arrive is, okay, if it is urea cycle defect, is it a fatty acid oxidation defect, or is it some lactate mitochondrial disorder, or if everything is normal, then think of certain amino acidopathies, right? And if there are any dysmorphic syndromes, dysmorphic features, you think of syndromes. Okay, so this is essential for you to not exactly narrow down, but come to a rough conclusion of where exactly the metabolism is in danger, right? So this again approach to persistent hypoglycemia I have talked about in our hypoglycemia or the infant of diabetic mother presentation. Okay, so just read that, and it is quite similar to whatever we have written, right? So one important test that we should never forget is always look for urine for reducing substances. Okay, glucose is a reducing substance, but look for urine for non-glucose reducing substance. If it is present and presentation in the newborn, then our diagnosis is galactosemia. Okay, if it is absent and ketones are present, look at lactate level. So lactate level, if it is high, then it is mitochondrial disorders, and some glycogen storage disorders can present with hypoglycemia. If the lactate level is normal, rule out our endocrinopathies and rule out some organic acidemias. So urine ketones are absent in fatty acid oxidation defect and hyperinsulinism also. Okay, not much of a confusion here. Very, very simple points I have included. I don't want to confuse further. So this is very simple algorithms that once you keep doing it, you will be able to identify. So I just want here the take home point is, don't think that metabolic disorders for everything you will have to send, you will have to wait till the TMS, GCMS report comes. Sometimes it is even more confusing once the reports arrive. So always have a mental framework of where exactly the metabolic problem sits based upon this simple algorithm. Okay, so all these basic tests you can definitely do it in your own facility, and then approximately just think, okay, this could be an urea cycle defect. So this could be a amino acidopathy. So because sometimes the TMS reports takes 2 to 3 days. Before that, you will have to start your treatment also. You cannot wait for the TMS report to come. If it is urea cycle defect, if there is hyperammonemia, so the treatment has to be initiated accordingly. Okay. So this is again a very simple algorithm. Say for example, urea cycle defects, only ammonia will be high. There is no ketosis, no lactate, and no acidosis. Lactic acidosis, you will have lactate, high lactate, and acidosis will be present. In organic acidureas, usually it is acidosis will be present. Ketosis may or may not be present, and even organic acidemia, sometimes there can be increased ammonia level, sometimes it can be normal. Maple syrup urine disease will have only ketosis. All these are negative in these. I told you, some amino acidopathies, NKH especially, all these will be negative. Okay, so it is not like sometimes we are just left with no clues. So we will have to have a clinical differential. So once you have done with the metabolic testing, what is the role of neuroimaging? Role of neuroimaging is very important because some of the syndromes do present with a typical structural malformation. So for example, Zellweger syndrome, as we saw previously in the image, it had sulcation abnormalities, the cortical migration abnormalities. MSUD, they present with brainstem edema, cerebellar edema, typical finding. And basal ganglia signal changes, if we find, then we can think of organic acidemias. And in Menkes kinky hair syndrome, NKH, there can be agenesis of corpus callosum. And very typically in glutaric aciduria, there is subdural hematomas. So all these with frontotemporal atrophy. So all these are typical neuroimaging findings. So definitely we have to do neuroimaging in metabolic disorders also. And not just stop with MRI, but always request for MRS from the radiologist. Okay, magnetic resonance spectroscopy. So once you give the clinical picture to the radiologist, they will see for these peaks, lactate peak, glycine peak, leucine peak. Glycine peak will be high in non-ketotic hyperglycemia. And leucine peak will be high. It's a branch chain amino acid. It is high in MSUD. Lactate peak is elevated in mitochondrial disorders. So always in a baby with suspected IEM, MRI with MRS has to be requested. Next, coming to the EEG. EEG, of course, with typical seizures and encephalopathies, we definitely do EEG. And in MSUD, the typical rhythm is a comb-like rhythm. And one of the common present EEG rhythms that we see is a burst suppression pattern is seen in NKH, and it can be seen in a holocarboxylase deficiency also. So CSF, again, CSF is for when the baby is representing with the encephalopathy or baby presents with seizures. Once the baby becomes hemodynamically stable, we do the CSF. We look for the amino acid levels. So CSF glycine is very much elevated in NKH, and CSF serine levels are low in serine biosynthesis defects, right? So these are all other investigations. So whenever we do collect samples, we have to have these points in our mind, because we rely a lot on investigations in inborn errors of metabolism. So when you do the testing, make sure before the specific treatment is started, you do the sampling. And sometimes when the baby is off feeds, okay, when the child is off feeds, it can become falsely normal also. So when the baby is at the crisis stage, you have to take the sample. Similar to that critical sample you have drawn during the hypoglycemia episode, isn't it? So do that. And for blood ammonia and lactate, when you do take the sample, immediately it has to be transported on ice to the laboratory and ask the laboratory people to immediately process it, right? And the lactate sample should be taken in a pre-heparinized syringe, and detailed history. So whenever you send the samples for metabolic testing, TMS and urine GCMS, give a detailed history, right? All the essential details, like if the baby was fed or not, did the baby receive any blood transfusion, what gestation it is, what was the birth weight, and family history. So all the details have to be given to them. Okay. So our treatment part is it is multifaceted. Okay. So once you find that there is some toxins of like say urea cycle defect, there is hyperammonemia. Our goal is to reduce the formation of toxic metabolites, reduce the formation of organic acids. At the same time, if the baby is on feeds, we have to provide adequate calories. That is also very, very important, and enhance the excretion of toxic metabolites. Cofactors has to be given. Biotinidase deficiency, the cofactor supplementation is important. Along with all the supportive care, temperature management, airway, breathing, circulation management, management of other metabolic parameters like hypoglycemia, hypocalcemia, etc. So, challenge, it is IEM baby management is a challenge. So, coming to the treatment part, so here it is, I am just discussing in brief, because we will discuss more and more in detail when we are talking about these disorders individually. So, starting from the long term, starting from the treatment, say I have not discussed about the urea cycle defect here. So, some disorders do have enzyme deficiencies. They, especially some aminoacidopathies, they have to be on lifelong treatment, say a phenylketonuria, a MSUD baby. So, they have to be on special diets to avoid these amino acids, and it is quite challenging also. But nowadays, some products are available in India, but they are very expensive. So, we will have to give a diet exchange list for them of what all can be included and what should not be included. And in urea cycle disorders, you will have to tell them how to restrict the protein, at the same time increase the growth of the child. Enzyme replacement therapy is available nowadays for lysosomal storage disorders, although they are very, very expensive. And cofactor replacement. So we do start on, sometimes before when we receive the TMS, we do start on this IEM cocktail therapy. Okay. So all these are cofactors which are responsible for metabolic, which are responsible for increasing the catalytic activity of the enzymes. So we do start on these cofactors as a cocktail, and then once we receive the TMS report, we stop. So thiamine, riboflavin, pyridoxine, biotin, cobalamin, etc. Even when during our status epilepticus protocol also, beyond the step 2, if there is resistance, then we do give a trial of IV pyridoxine, we do give a trial of biotin to check if the baby is responding or not. So these are all replacement with cofactors. And whenever you have a clear-cut history of sibling death in the family, don't discharge the baby until the first week. So always keep the baby under observation. You start the baby with breastfeeding, but make sure it is less. Okay, you keep the protein intake to minimum and then gradually increase it. So once the baby reaches full feeds, keep the baby under follow-up for another 2 to 3 days. After you establish the full feed, if the baby is doing well, you can discharge. Otherwise, do a complete metabolic screening also for this baby, and then make sure there is no treatable IEMs, and then only we can discharge. Prevention of IEMs is what we are most concerned with, and in our video lecture on newborn screening, I have mentioned about what are the newborn screens that we have to do definitely, and how, what is category B, what is category C newborn screen, etc. If you have not gone through it, please go through. So what is the cornerstone of prevention is genetic counseling. Already if the parents have a baby with certain metabolic disorders, counsel them. During the second pregnancy, CVS and amniotic fluid can be taken as samples in amniocentesis and chorionic villus sampling, tested, and they can be clearly counseled regarding that. And DNA based diagnosis is now the gold standard. So next generation sequencing, whole exome sequencing have come. So all these have to be counseled to the family and made sure that we don't miss any IEMs, treatable IEMs, and so that no baby lands up in a crisis. Okay. So I hope this presentation, it is not a very elaborative one, and I wouldn't say it is a very comprehensive one, but I just wanted to give you an overview before we start discussing these metabolic disorders in detail one by one. Okay, I hope it is simple for you. If any doubts, clarifications, please give us a call or write to us. Thank you everybody for the patient listening.